Folks from Kaiser Permanente to speak about population-based identification and outreach for new-onset psychotic symptoms. And I will turn it over to Dr. Gregory Simon, who will be our chair and discussant.
Thanks. So what we hope to do in the next hour or so, followed by some discussion we hope with all of you, is to talk about the results of an R01 that was funded by NIMH a few years ago, focused on population-based identification and outreach for people with new-onset psychotic symptoms. We'll be basically marching through the aims of that project. Jen Boggs will be talking to us about estimating incidence in a defined population and sites of presentation. Arnie Beck will be talking about the patterns of care we observe in people before the first presentation with psychotic symptoms. Bobby Jo Yarbrough will be talking about patterns of care after people receive a diagnosis, especially focused on treatment continuity. I'll talk about what we've seen in terms of excess mortality following first diagnosis of psychotic disorder. And then Bobby Jo will talk about some work, both some qualitative work and then some pilot work on assessing the acceptability and feasibility of outreach interventions. So before I turn it over to Jen, talk about the overall project. So the MHRN, or Mental Health Research Network, First Episode Psychosis Project, was conducted in 5 health systems. It was at that time Group Health, although it's now Kaiser Permanente of Washington. Together, these health systems serve a defined population of about 8.5 million members. The members are all insured, but they come in through various types of insurance, including a substantial number of people insured via Medicaid, via Medicare, and various subsidized low-income programs. The population served by these health systems represent their service area, so they're fairly diverse overall in terms of race and ethnicity, but the people from Portland look like Portland, and the people from LA look like LA. These systems, and this is why this research is possible, are able to bring together the data, both the electronic health records data for services that are provided by these health systems and insurance claims data for services that might be provided by external providers but are paid for through our health insurance. And all of these data come together at the different health systems in a standard format, what we call our virtual data warehouse, which follows a common data model. And in research like this, typically what we're able to do is to do that research in a distributed fashion, to write programs that can then extract, organize, and analyze those data at the different sites, although in some cases we do need to bring the data together for more complicated analyses. So with that as background, I'll turn it over to Jen, who'll talk to us about the first tier question, which is, can we accurately identify first presentations with psychotic disorder, and what does that tell us about the true incidence?
Great, thanks. So I'm going to talk a little bit about how we estimated the incidence for first episode psychosis across the 5 health systems. Looking at the literature, prior estimates of psychosis incidence have had a lot of variability. They range from 15 to 100 per 100,000 patients. You notice higher incidence recorded in studies of medical records and lower incidence in studies of surveys. Interestingly, a lot of the prior work has been limited to young adults, so they'll have an age restriction less than 25, less than 30 years of age, and we actually looked at a much broader age range, which turned out to be quite interesting, as you'll see in a few minutes. One of the important questions we also looked at was the care setting in which first episode presentations were occurring. There's a lack of data in the literature on this, and this is an important question because if you're going to have interventions for individuals with first episode psychosis, you need to know where they're showing up. So our initial medical record scan, where we used ICD-9 codes for psychosis to find first episodes, found 37,843 cases across the 5 health systems. We had an age range of 15 through 59 that we applied as to our sample definition. And we also required that they be enrolled in the health plan for at least 12 months prior. And the reason for that was so that we could go and confirm that they actually were first episode cases. As you can see on the slide there, we looked at a couple different categories within the ICD-9 diagnosis. We looked at schizophrenia spectrum disorders, mood disorders with psychotic symptoms, and other psychotic disorder. Interestingly, other psychotic disorder was the most prevalent that we found. And I think that makes sense because providers may be hesitant to give a schizophrenia diagnosis on the first presentation of psychosis. We also excluded patients that had dementia or neurodegenerative disorders. Thinking about our case definition, I think it's important when you look at the waterfall of how patients came into our cohort, because you'll see that we lose quite a bit after that first diagnosis of psychosis during the study period to the age and the enrollment criteria, and we lose, I think, most of them to the enrollment criteria. We need to apply that criteria so that we can confirm, but thinking about the incidence that we're estimating and how many actually first come in, I think that's something to consider when we think about the magnitude of the problem. So we did chart review confirmation of 1,337 cases across the 5 health systems, and I was actually one of the chart reviewers on this project. These cases were selected based on age and site of presentation. The goal of this chart review was to confirm that they had presence of the DSM-4 criterion A symptoms, and to also confirm this was actually the first episode and they didn't have prior treatment for psychosis. So if they had any prior treatment more than 60 days prior, then we would consider that not a confirmed case. We also excluded them if they had any definite medical exemptions or medication exemptions where the provider clearly attributed the psychosis to a medical diagnosis or a medication. And I'll show you an example of that in a second. We did not apply exclusions related to substance use or mood symptoms. So if it was a code for substance-induced psychosis, we didn't include those in our definition. But if there was co-occurring substance abuse and psychosis and they used a code like other psychosis, we did include those. So on the not confirmed side, these are examples from the chart, actual documentation de-identified from the chart. I wanted to highlight a couple of things where we weren't able to confirm them because they were a little too vague. So the first one, he sees things in cards and enjoys messing with people. Well, like maybe it's delusions, I don't know. So there were some documentation of these along these lines that we couldn't really confirm. So that was one of the reasons where we would kick a case out. It was because we couldn't confirm there actually were criterion A symptoms from the documentation. Another one was that there was evidence that there may have been prior treatment. So you can see here at age 18, he started having hallucinations. So that is a clue like, oh, I need to go look and see what happened at age 18. And then also delirium. And as you can see there on the slide, they attributed the psychosis to herbal medication use that was psychoactive. A confirmed case, an example of confirmed case is on the other side. So a patient has been hearing voices for about 1 week, so the duration for about 1 week is important. He said they're always there, but it later goes to say his parents reported that patient has never experienced this type of episode before. So this is a really good, clear distinction between we are detecting the first treatment of psychosis, not necessarily the first experience of symptoms. And so with the literature, when you look at survey studies, they may be looking at the first experience of symptoms. We're looking at the first treatment. And then the last part of that, it says, I discussed that psychosis could be related to any or all the factors including sleep deprivation, legal stimulant use, cannabis use, or depression. I think that just shows like difficulty with which providers can attribute the cause of psychosis. It's pretty hard to do in most cases. So looking at the estimates that we determined based on the initial incidence, and then we did an adjustment for the confirmation rate that we detected from the chart review. So as you can see, the initial incidence was about 125 per 100,000 in the younger group. And then in the older group, we saw a fairly high incidence as well, which I think is somewhat of a novel finding. Interesting, in our chart review confirmation, you'll see that the confirmation rates for the younger group are much better. And specifically, they are much better for in the ER inpatient setting. So the range is from 19% confirmation up to 84% for that younger group in the ER inpatient setting. And then we adjusted the incidence based on these confirmation rates as well. Sorry, 1 second. So the final incidence that we arrived at was 86 per 100,000 for the younger age group, and then 46 per 100,000 for the young or older age group. So a couple conclusions from this. Inclusion of multiple care settings increases the estimated incidence of first episode psychosis. And importantly, what I forgot to mention was that if you look at the care setting where folks were showing up, the outpatient mental health setting was the highest among the couple care settings, but there still is a fair amount of folks that are showing up in the primary care and medical setting, about a quarter to a fifth of cases. We also detected substantial first episodes of psychosis after 30 years of age, and this could indicate that this was a previously overlooked group that we need to think about interventions for. Finally, a chart review is essential when you are trying to ensure accurate estimates for things like first episode psychosis from the medical records. You could see, especially in that older group, our confirmation rates were not as high as they were in the younger group, but we still detected, that there were substantial first episode psychosis in that group. So a couple limitations to think about. Our sample does not include uninsured people, and so we hypothesized that potentially with a group of uninsured people, that detection in the ER setting may be higher than the mental health outpatient setting, because supposedly most of these folks would have had access to mental health care. 10% of our sample were not available for review, so this could impact our confirmation rates and ultimately our final estimates of incidence. And then finally, as I mentioned earlier, these estimates are limited to patients that are seeking care, not the first occurrence of the symptoms, which is likely why we see we see that group, the older group that is maybe first seeking care when they are a bit older, but may have experienced symptoms for a while before that. Okay, so now I'm going to hand it over to Arnie Beck, who's going to talk about patterns of utilization prior to first diagnosis.
Thanks, Jen. So yes, I'm going to talk about patterns of utilization prior to first diagnosis. And as some background, we know that early detection and intervention are important for first episode psychosis. In fact, delays in receipt of effective treatment are associated with poorer outcomes later on. And we know that early intervention can be very helpful in terms of reducing symptoms and improving functional impairment. The RAISE trial really demonstrated that very well. Even in the RAISE trial, there was an average of about 18 months before treatment initiation. So one of our questions is, can we do a better job in our types of systems of early identification of these individuals to get them into treatment sooner? We also know, and Jen was just talking about this, that a substantial minority of our patients actually have their diagnoses that occur outside of specialty mental health care settings. And in trials like the RAISE trial and some others, typically these patients are seen in specialty mental health or community mental health settings. So we sort of cast a wider net in our look for first episode psychosis and utilization patterns. And we think that early detection should include a wider range of care settings. So specific questions are, what types of care were received prior to first diagnosis of psychotic disorder? And particularly, how do these patterns of care compare to the general population of health system members? And this question really helps us identify whether there's sort of signals and utilization patterns that we might be able to identify for these patients with first episode psychosis. And how do these utilization patterns compare to those diagnosed with unipolar depression? And this could help us differentiate between those with psychotic disorders versus those with more sort of general distress, that might be indicated by a diagnosis of major depression. So our sample definition was folks from ages 15 to 59 enrolled for at least 12 months in the health plan, and a recorded ICD-9 diagnosis between 2007 and 2013. We selected a random sample of 1,000 potential cases to do a more detailed chart review of all encounters 60 days prior to and 60 days following the index diagnosis, and this was to confirm a true case. Our comparison groups, as I mentioned, were two: the general population of health system members and those diagnosed with unipolar depression. We selected 3 controls per case for each of those control groups. They had to be enrolled for at least 12 months prior to the diagnosis or visit, and they were matched on age, sex, health system, and the year of diagnosis or visit, plus or minus 2 years. The benefit of our systems, of course, is that we have comprehensive data on utilization, so we could look at electronic health records, insurance claims, pharmacy dispensings, and inpatient services, as well as psychiatric medications and diagnoses, all up to 36 months prior to the initial qualifying diagnosis. We excluded that utilization 7 days prior to the initial qualifying diagnosis, because these could be really related to the presenting diagnosis. So what did we find? It's a little bit of a busy slide, but I'll walk you through it. We had 624 confirmed cases based on that chart review, and this describes their patterns of utilization. And essentially, you'll see that a small percentage, around 4, had hospitalization with a mental health diagnosis up to 3 months prior to the diagnosis. That went up to, at 36 months, 13%. There was a greater percent, 14% at 3 months, for emergency department utilization, and 33%, a whole third of that sample, actually had ED visits within 36 months of their diagnosis. And there was a greater percentage of specialty mental health care use, 20%, which went up to 38% within 3 years of diagnosis. And when you put all these together for any of the above diagnoses, any of the above mental health related encounters with the mental health diagnosis, that was almost 50% of the sample. And that was about 3/4 of the sample within 36 months. So these folks are utilizing services both in acute settings and outpatient settings, both in mental health and primary care. As far as the diagnoses, most of the diagnoses for this group were in the mood disorders category, so depression and anxiety. But there were a number of diagnoses around substance use disorder, 17%, and 45% had any diagnosis, mental health diagnosis, within the first 3 months. And most of the prescriptions were for antidepressants, and benzodiazepines, and antipsychotics. And a majority, or a substantial minority, I should say, had any psychiatric medication, any psychotropic medication. So how do these compare to the general population of health system members and those diagnosed with depression? Basically, this slide shows that and I limited it to 12 and 24 months because it's still busy that way, but we had data on 3 and 36 months as well. But compared to the general population of health system members, the controls, there was a higher pattern of utilization across all services for those with a psychotic disorder, the cases compared to them. And interestingly, these differences were a little bit attenuated the longer period of time you went out prior to the diagnosis compared to the general population controls. The greatest differences were in acute care use, so emergency department visits and hospital admissions. For the depression control group, the differences in those in outpatient mental health services were less pronounced. There were modest differences, and there were no significant differences between the cases and the depression control cases, depression controls, in general outpatient services with any diagnosis. But again, the pattern of significantly higher use of emergency department and inpatient services was seen in those with a psychotic disorder. And those patterns stayed pretty similar, pretty stable over the 3 years prior to first diagnosis. And so the relative odds were around three times greater for those with a psychotic disorder compared to those with a depression diagnosis. So what do we learn from this? 30% of individuals with a psychotic disorder had some type of outpatient specialty mental health care in the previous year. 2/3 had any mental health care. The use of these services was higher among those than in the general population, but a similar pattern of utilization was seen in those later diagnosed with depression. The psychotic disorder group, though, had greater use of acute care mental health services than the depression group, including inpatient and emergency department care for mental health diagnoses. So this is kind of telling us where we might want to focus efforts. There were several limitations, of course. The low incidence of psychotic disorder diagnoses is pretty low, so for the medical settings, this may not be the area where we want to focus. But there is potential utility of identifying these individuals in higher acute care settings. And so for limitations, we identified, and Jen referred to this, that these were the first diagnoses rather than the first symptoms. The first symptoms could have had onset months or years before the diagnosis was actually recorded. And those symptoms could have prompted prior utilization even if they weren't disclosed. Previous antipsychotic scripts could have indicated providers' reluctance to record a diagnosis. So they could have been prescribed for an antipsychotic for psychotic disorder, or could have been for a mood disorder, and those are things that would have to be disentangled, really. And then, of course, we have to be cautious about generalizing to other healthcare systems and populations for these results. So, most people receiving a first diagnosis of a psychotic disorder did use primary care and outpatient mental health services in the past year. The service use did not differ from those receiving a subsequent depression diagnosis. And acute care mental health services, that's inpatient or emergency department care, is a more specific risk indicator. So when we want to think about assessing these patients and doing early identification, these are the settings that we want to think about targeting for those folks. Next, Bobby Jo Yarborough is going to talk about follow-up care after first diagnosis. Thank you.
Okay, so picking up where Arnie left off, and our background slides are similar, I noted. So as Arnie said, we know that outcome trajectories of first episode psychosis are established early, and duration of untreated psychosis is a risk factor for poorer outcomes. Untreated psychosis can disrupt family and social relationships and educational and vocational pursuits, setting off a deleterious trajectory. Successful treatment can alter prognosis, but we know that delays in initiation of effective treatment are common, unfortunately. And so we were asking with this next set of slides, what type of health care were received following a first diagnosis of psychotic disorder? And in the short term, at 6 months, which proportions of patients have not initiated services, have discontinued early, or continue to appear to receive visits or medications? Again, we were using EHR records, insurance claims, pharmacy dispensing records to identify all utilization of mental health services and psychiatric medications in the 6 months following the first recorded diagnosis. Okay, so let me orient you to this slide. This is showing cumulative initiation of healthcare service use and dispensed medications after the first diagnosis. And so on the first column, let's see if I can, there we go. Here you have the services that we were looking at in terms of outpatient follow-up care and acute services, and then the psychiatric medications. And then each column thereafter represents a time period after the diagnosis. So here's the immediate 2 weeks following diagnosis, and then 1, 2, and 3 months. And so clinically, ideally, you would expect to see someone with a confirmed first episode psychosis, hopefully getting services within the first couple of weeks. And when we look at the results here, we see that about a quarter received specialty mental health visit, some kind of individual visit with either psychiatry or psychologist, a licensed therapist. And about 40% had any outpatient mental health visit in the 2 weeks following the diagnosis. About just over 10%, 11.2%, had any emergency department or inpatient visit, and about 30% received an antipsychotic in the 2 weeks following their initial diagnosis, and about 40% received any psychiatric medication. And then when you dial out to a month, you see that those receiving any outpatient mental health follow-up rises to 52%, and at 3 months, 2/3, 66%. And then again, in terms of prescriptions, more than half, 57%, received an antipsychotic by 3 months after the diagnosis, and again, about almost 2/3 received any psychiatric medication in the 3 months following their first diagnosis of psychosis. Okay, So this slide is showing continuation of healthcare service use and, again, the same dispensed psychiatric prescriptions. And so this time we split the sample. We're looking at just the 6-month period after the index diagnosis, and we split the sample into 3 groups: those who never initiated a service and or medication during the 6-month follow-up window, those who appear to have initiated, either they attended a visit or they had a fill for a prescription within the first 3 months, but not within the later 3 months of that time period. And then here you have people who initiated a service and or medication and appeared to be active, which we defined as having a visit or a medication fill within 12 weeks, or in this case, 3 months of the end of the window. So we have, again, about, in this case, about roughly a third of the sample falls into each of these categories if you're looking at their outpatient mental health visits. So roughly a third never initiated any outpatient mental health follow-up. Roughly a third had some follow-up but didn't appear to continue. And then roughly a third were still receiving services in the months 3 to 6, or had at least a visit in months 3 to 6. So at least minimally getting services. And then down here, when we look at antipsychotics, which if you look across these medications, antipsychotics are the most often prescribed, which makes sense for this diagnosis group. And you have about 40% getting an 40% never initiating an antipsychotic in the 6-month period. About 35% initiating and continuing to fill prescriptions during the 6 months. And about a quarter getting any psychiatric medication, or never initiating any psychiatric medication, and about half initiating and continuing to fill prescriptions for any psychiatric medication. So about 2/3 of patients received an outpatient mental health visit in the 3 months after the index diagnosis. A quarter had acute care services within 3 months. More than half had 1 or more prescription for an antipsychotic that they filled. 65% had any psychiatric medication by 3 months, and at 6 months following the index diagnosis, about a third had had no outpatient mental health services, a third had initiated but discontinued early, and a third remained at least minimally engaged. And then I think I mentioned individual visits were the most common service, and antipsychotics the most common prescription. Greg's going to talk about mortality.
So I'm going to shift here to a different sample. Bobby, Joe, and Arnie have been talking about a smaller sample of people who, what we call confirmed cases, people for whom we reviewed charts and were able to confirm that they truly did experience psychotic symptoms and that this truly was the first clinical presentation with psychosis. We were actually inspired, as I'll say in a minute, to look at mortality by some publications that came out while our project was in process, and we knew we would need to look at a much larger sample. So the sample I'll be describing to you here is a different one from what you've heard about a few minutes ago. First, a few words of background. As all of you know, there's a well-documented excess mortality in people with psychotic disorders and other severe mental illnesses. A lot of the concern has been focused on long-term mortality and chronic medical illness, especially excess mortality due to cardiometabolic diseases in people with bipolar disorder and schizophrenia. There has been some recent publication. Michael Schoenbaum from NIMH and colleagues published a couple of years ago a paper on a sort of mortality spike or marked increase in mortality shortly after first diagnosis of psychosis. In those data, they were not able, though, to look at specific causes of death. So what we were hoping to do in this sample was to examine mortality following a first diagnosis of a psychotic disorder, to look at how that compared to people who had received a first diagnosis of unipolar depression, or to the mortality in an aged match sample from the general population, look at what specific causes of death account for that excess, whether that excess mortality might be explained by pre-existing differences in chronic medical conditions that people had prior to diagnosis, and then to examine how those mortality patterns change over time. So here we'll be looking at a larger sample. These are people who, similar to the samples you've heard about before, received a first ever diagnosis of a schizophrenia spectrum psychotic disorder, a mood disorder with psychotic symptoms, or an other psychotic disorder diagnoses. These were diagnoses that were recorded between September 30th, 2009 and September 30th, 2015, so we didn't have to deal with transition to the ICD-10 diagnosis codes. Also, we needed to have some time period for mortality follow-up. We limited to people age 16 to 30 at time of diagnosis, both to match the previous publication, but also because we know from the work that Jen described to you a few minutes ago, if we just straight up accept a diagnosis out of the records in people over age 30, a large number of those either may not have a psychotic disorder or it may not be a first presentation. We still required people to be enrolled for 12 months prior, but these were not confirmed by chart review. If you remember back to one of the slides Jen showed you, we'd expect that 80% or more of these would have been confirmed had we reviewed the records, but we simply didn't have the resources to review that many records. So we had two comparison groups. We compared this sample to a group of people who had a first diagnosis of unipolar depression during the same time period, 2 controls per case. Another sample of people who were outpatient visitors. I can talk about that in a minute. This is, you wouldn't say exactly a general population sample. These were people who made at least one visit, so they probably are a group of people who may have somewhat more likely to have some medical illness than the general population. Controls were also enrolled for at least 12 months prior to the diagnosis. The controls were matched to the cases on age within a band of 2 years, matched for sex, matched for the health system from which they were selected, and the year in which their eligibility diagnosis or their eligibility visit occurred. We identify mortality outcomes by linkage to state mortality data. The mortality data are actually not, they're available. We link for all people who have ever been members of these health systems. So even if someone disenrolls from the health system or no longer insured, we're still able to ascertain the fact and cause of death. So we don't need to censor the follow-up here according to enrollment in the healthcare system. We classified causes of death into some broad categories: self-inflicted injury or poisoning, accidental injuries or poisonings, death by assault, death due to cancer, cardiovascular disease and diabetes are the broad category of cardiometabolic diseases, and then all other causes of death. We use the Charlson comorbidity score to examine the medical conditions people may have had at baseline, dividing the Charlson up, the individual indicators into some of these broad categories. So we end up, in terms of this sample, with about 11,000 likely cases of first episode psychosis in people who are aged 16 to 30. They were 59% male. You can see the age distribution there. And in terms of baseline characteristics, what you see here is the cases with first diagnosis of psychotic disorder and then the control groups. In terms of the distribution of race and ethnicity, you can see that, as expected, the people with first episode psychosis diagnosis were more likely to have had a mental health diagnosis in the prior year. They were slightly more likely to have had chronic illnesses according to the Charlson comorbidity score, but not that much more likely, and you can see the specific conditions there, chronic lung disease being the most common chronic medical condition in this group. So when we look here at the 12-month mortality, comparing the three groups, what we see is that the crude mortality rate, the death rate per 10,000 persons per year, is about 55 in the psychosis group, compared to 2.5 times as high compared to about 20 in the unipolar depression group, and nearly 10 times as high compared to the general outpatient group, somewhat similar to the findings that Michael Schoenbaum and colleagues had published. What we're able to do here is to look at specific causes of death, where you can see the most marked excess is in the categories of self-inflicted injury or poisoning, accidental overdose, and assault, where we see that the first episode psychosis group has moderately increased rates over those with diagnosis of unipolar depression and markedly increased over the general population or outpatient visitor sample. The comparisons are here. If we look at the relative hazard of death over 12 months, here we're able to adjust for race and ethnicity. Their age and sex matched, although we can still adjust for that, but also adjust for the Charlson comorbidity score to account for any medical conditions people may have had prior to diagnosis. What we see is that the overall hazard of death compared to the general outpatient sample is about 7 to 8 times higher in people with first episode psychosis diagnosis. Compared to those with diagnosis of unipolar depression, it's about 2.5 times as great. But the big differences are in self-harm or self-inflicted injury or poisoning, where we see the FEP group compared to the general population had about a 30-fold increase in mortality. Compared to even to the depression sample, it was about a 1.5-fold increase in mortality. Less marked, but still, significant differences in terms of other injury or poisoning diagnoses. We see actually no difference related to cardiometabolic disease, which when you think about it is not that surprising. These are predominantly 18-year-olds who are relatively healthy. But as we'll get to, what this is saying is, the concern about excess mortality in people with psychotic disorders probably really needs to bifurcate into the acute and chronic pathways because we're dealing with very different problems. When we look at mortality trends over 3 years, what the graph shows is we're looking in the left at the overall mortality rate, death from any cause. The middle is death rate from injury or poisoning, and that's either accidental or self-inflicted. And in the right is death rate due to other causes than injury or poisoning. What we see here is, that excess mortality is clearly greatest in the first year, which is in either of those graphs. The leftward point drops down into the second and third year, although the overall mortality rate in people with FEP diagnosis still remains quite elevated over the general population and over people with unipolar depression. We see the differences are about half of that excess is accounted for by injury and poisoning. We see that clear time trend in terms of the injury or poisoning having that high peak in the first year and then declining, but less temporal change or less time change in the other death due to other causes. So in terms of limitations, this is an insured population where people had access to health care. Even though they may have been insured by Medicaid, these were not all employed or well-off people. They still had access to an integrated care delivery system. We do know that some of what we're counting as cases in this sample will be false positives. Our best estimate is that maybe 20%. The false positives could be because people were said to have a psychotic disorder when we might not believe that they really had one, or this might be a new recording of an old diagnosis, although that's less common in younger people. We're looking at people when they first presented for care. They may have been experiencing symptoms for months or even years ahead of that time. We're also comparing in the so-called general population to people who made at least one visit, not really the general population. All of these would tend to introduce a conservative bias if we're comparing our first episode psychosis cases to other people. So if anything, the true excess mortality or the ratio of mortality may be greater than what we're reporting here. So at placing this in context, this is certainly consistent with other data published recently here in the US, but also in other countries, showing a high risk of what you might call unnatural death. That means death that's due to self-harm, to assault, or to accidental overdose or accidental injury early in the course of psychotic disorder. And that the causes of excess mortality in people with psychotic disorders are quite different if we're considering younger people who've been recently diagnosed and older people, even middle-aged people who've been living with a psychotic disorder and with treatments for a psychotic disorder for some years. So in terms of conclusions, markedly increased risk of unnatural death. I think as we're seeing the sort of growing evidence for the effectiveness of early intervention programs, we need to think about the implications. Certainly there's some observational evidence that continuous treatment with antipsychotics in people with psychotic disorders can reduce mortality. And I think for early intervention programs, a really special attention toward risk of self-harm. It appears there really is a mortality spike that's compared even to unipolar depression quite dramatic in people soon after diagnosis of psychotic disorder. So this should be, I think, a special point of emphasis for early detection intervention programs. So now I'll turn it back over to Bobby Joe, who's going to do our last sort of presentation before we have some discussion.
Okay, so from this body of work, we learned from Jen's data that she presented that we have higher than anticipated rates of people receiving first episode psychosis diagnoses in our health systems. And from Arnie's work that many of them are receiving some kind of mental health treatment prior to that first diagnosis. From the data that I showed earlier, that 2/3 are receiving some outpatient follow-up within 3 months of their first diagnosis, but only 1/3 are continuing to receive that at 6 months. And then we've just heard from Greg about this high risk of death by unnatural causes in the very early period following diagnosis. So we were asking ourselves, what can and what should we be doing about all of this? And we interviewed health system administrators and clinicians, 15 of them across our 5 health systems that were a part of this larger study. and patients and family members, patients who had recently been diagnosed with a first diagnosis of psychosis, and their family members when they were when they consented to that. And so I'm going to be presenting a couple of themes from those qualitative interviews, and the first three, I believe, are cross-cutting themes that we heard from each of these three interview sample groups, and then I'll focus in a little more closely on some things that we heard from clinicians, particularly about engagement after the first diagnosis. So the first theme here, early on, some individuals experiencing psychosis hide symptoms until they can make sense of them. So we have a male here, age 19, who says, I just got better at disguising and hiding. I think that's what's easier at first, to just not deal with it and to pretend it's not happening. And a female, age 21, I tried to keep it to myself because I honestly thought that it's just going to go away. It's not something to worry about. I don't want somebody to think I'm crazy, and so I just didn't tell anybody. I'm showing this theme just to demonstrate the context that as this illness is becoming apparent to the person experiencing it, their native instinct or reaction is not to outreach for care. They're not asking for help. It's to sort of try to sort through it and figure out what's going on and keep it to themselves. And we have a clinician who said, the ones that fall through the cracks are oftentimes the one where the child learns how to hide the symptoms from the parent, and they're very good at it, I'll tell you, for short periods of time. So then our next theme is symptoms become more difficult to mask. Some individuals isolate themselves, making it harder for others to recognize problems. So we have a parent that said, we saw an extreme change in his behavior and his personality. He no longer wanted to participate in anything that involved social interaction, internalized everything, and kept it internally. And then an administrator who talked about when patients come in for routine care, how these kinds of symptoms can be missed. They said, along with the psychosis is often depression and isolation, and it's the isolation more likely that causes the concern of primary care. But the PHQ-9 can't catch that. It's a bad barometer for these illnesses. And if we don't have any other easy barometer to help primary care become more aware, it really will be, and always has been, dependent on the family to say that there's something wrong with my child. So we have a context where the child or the young person experiencing these symptoms isn't forthcoming about them because they're trying to make sense of them on their own. They're also then isolating and withdrawing, so it makes it more difficult for their parents to recognize what's happening, and we have a system where we're relying on parents to recognize that and bring them in for care. And then finally, caregivers often attribute social withdrawal to typical teenage behavior. So we have a parent who said, I think probably the earliest things I noticed were some depression. She was still doing very well in school, but she was spending a lot of time on her own in her bedroom, which I kind of ascribed to typical teenage behavior, as many of us probably would if we didn't know there were other symptoms happening. And we have a clinician here, in fact, several clinicians who talked about two different types of families, those who lacked exposure to serious mental illnesses and therefore didn't know what to look for and how to recognize symptoms, and then those who had family histories of psychoses and were unwilling to sort of acknowledge that that might be happening in their own children. And so we have a clinician here who said the ones that fall through the cracks are oftentimes the ones where the parents, for some reason or another, think this is just adolescent behavior. So these themes kind of give you an idea of the context of what's happening in the environment before people come into care and why there may be delays in care seeking. These next themes are just from the clinician interviews and their report of barriers to engagement at the patient level, and then I'll share some about the organizational and system level barriers. So here we have a clinician who said, many first-time people with psychosis are difficult because they don't want to have the illness and they want to deny it. And they will say that they're fine and they'll go off their medication. So convincing people to get adequate follow-up is really a burden to the clinician. Another clinician said it's hard as heck to get the adolescents to come back in. Quite frankly, it's more initially, we're more oftentimes than not using the parent. We're their source of information, their emotional support. We're there to help them with the importance of the medication during this acute phase and how terribly important it is that they make sure they're monitoring the client for the meds, because most adolescents, frankly, do not want to take meds. They don't want to feel any different than any other adolescent, and so medication adherence is a huge factor. And then at the organizational or system level, one administrator sort of summarized the way that we organize care and how it's not set up for this particular patient group. So our department is set up in what I will call a traditional outpatient model, not shifted to treat someone with a chronic or developing schizophrenic diagnosis or schizoaffective diagnosis. And so we do not necessarily currently have the supports for that population in regards to working with the family, giving them resources, working with the person to help them understand what it means to have this illness, what it doesn't mean to have this illness, and helping them recognize what they need to do in order to maintain stability with this illness. And then another clinician similarly said treating communities are not really set up to do the kind of cautious engagement using peers, using outreach programs, the kinds of services that are needed to try to engage people. And so with all of this, we decided to try to develop a systematic outreach and engagement intervention. And our goals were to assess feasibility of using telephone outreach to evaluate psychotic symptoms and general functioning, because that's what our systems would naturally tend to do when they're approaching a problem like this, is to assign a care manager and use telephone outreach. And we wanted to see if we could improve engagement in usual care, and when indicated, make a connection to coordinated specialty care clinics in the community. And so this was a very small pilot. We did this in Kaiser Permanente Northwest in Portland, Oregon, and Kaiser Permanente, Washington. And we leveraged the existing case-finding algorithm that Jen described earlier from our larger first episode psychosis study to identify potential patients aged 15 to 29. So we stuck with the lower age range sample for this pilot study. We were looking for people with an incident diagnosis in the 5 months between January and May of 2018. And then again, because there are a number of false positives that show up with the case-finding program, we had a chart review to eliminate cases that didn't have clear evidence of either psychosis or that it was the first episode of psychosis to determine patient eligibility. And then in this case, we contacted clinicians for approval to outreach to their patients, just in case they knew about things that maybe weren't documented in the chart that would suggest that it wasn't an appropriate time to outreach to the patient. So in our outreach call, we were hoping to assess current psychosis symptoms, and we were using the prodromal questionnaire brief. So this is not an instrument that was necessarily designed for this purpose. There aren't really, this was one of the first problems that we were sort of struggling with, is like, well, if we can even get these people on the phone, what instrument are we going to use to sort of screen and see how they're doing? So this is an instrument that's made really to look at symptoms in clinical high-risk patients who are already sort of in a care pathway, not really for general use in the community. So that was one sort of experiment, is can we use this instrument? Will it work? Will it get us the information that we need to sort of find out how people are doing? We also wanted to assess social and occupational functioning using the global functioning scale, which is sort of measures patients' engagement with their family and friends and in school and work and other role obligations. We asked participants to report any facilitators or barriers to psychosis care, and we assessed their current engagement in care, and then encouraged continued engagement in care as appropriate. And if they were disengaged, we tried to offer assistance to reconnect with usual care that they had access to. And sometimes that meant, if they were dissatisfied with whatever clinician they had been seeing and so they weren't going anymore, we were trying to get them connected with a new clinician. Or if they were dissatisfied with medication and so therefore no longer attending visits, we were trying to help them see maybe the benefit of re-engaging in visits, whether or not they decided to resume medication treatment. And then we referred people to local coordinated specialty care programs when that was appropriate. So our case-finding algorithm yielded almost 250 participants during the 5-month period. 2/3 of the cases that we reviewed in the charts were ineligible to continue for the outreach intervention. And so I'm showing the reasons for that here. The most common reason was that there was no evidence of psychosis in the chart when we looked at it. Again, the algorithm that we used pulls both people who received a diagnosis in specialty mental health, but also people who received a diagnosis in primary care. And so sometimes there are different, as we talked about earlier, different rates of confirmation of those diagnoses. So 30% had no psychosis documented in the record. 15% it was unclear if what they were describing was psychosis. And then about 10%, which is the same that Jen reported in the larger trial, we had no records to determine whether or not the person was experiencing a first episode psychosis. So those are patients who are members of our health systems, but they were probably diagnosed at an external facility, and those records hadn't made it back into our records. And then, so there were about 1/3 that were eligible to continue. And among those, about 5% the provider refused contact on behalf of the patient. Just about 10%, we had no good contact information in their medical record. We had no way of reaching them. And then about 45% of the eligible cases, we were unable to reach by phone despite a number of calls and leaving messages. People just did not call us back. In 6% of cases, we reached the parent who either declined on behalf of their child or we just never were able to connect with the patient. And then in 10% of cases, we reached the patient, but they were not interested in being part of the study. 30% agreed to the outreach call and assessment, and the interviewers felt that the assessment instruments that we were using did give them a good sense of the participant's psychiatric status and needs. And then with about 4%, with all of them, we tried, as I said earlier, to get them engaged in the usual care services that were provided by the health system. And then with about 4%, we referred them to coordinated specialty care with a warm handoff, meaning that if we had them on the phone, we did a 3-way call to the coordinated specialty care program and transferred the patient over directly. In 8% of cases, the patient was interested in hearing about coordinated specialty care. We sort of told them all about what those services looked like. We gave them the phone number, we gave them the web address, but they declined a warm handoff. And so often in those cases, we would just offer to check back in with them to see if they'd made a connection. And then 2/3 of the people that we did an initial assessment with, we were able to do at least 1 and sometimes 2 more follow-up calls after that. So if we were able to get people on the phone, they were generally willing to answer our questions and do our assessment and even do a second or third assessment as well. So our recommendations from the pilot, as Jen pointed out, we knew this from the earlier study, cases diagnosed in psychiatry compared to primary care were more likely to be true first episode psychosis cases. Systematic collection of good contact information and collateral contacts would have really facilitated our outreach efforts, so that suggests that there's a need for a workflow that when a first episode psychosis diagnosis is made, there's some effort to get adequate contact information before the patient leaves your office so you have a way to stay in touch with them. Phone outreach is probably not the best way to reach young people. Young people don't answer their phones, whether they have first episode psychosis or not. We weren't able to test whether email or text messaging might have been a better way to get more people engaged in our program. The PQB, as I said earlier, was not intended for use as an outreach measure of psychiatric status, but nevertheless provided helpful information to distinguish patients with clinical needs from those who seemed to be doing okay. And the role and social functioning scales also helped to distinguish patients who appeared to be moving toward recovery from those who weren't. And I believe that is the last slide, yeah.
Now it's working. Okay, they turn it on the back. We have plenty of time for discussion and would welcome any of your comments, suggestions. But, maybe I'll start, more with a question for Bobby Joe, but for anybody else who was involved. One of the reasons why, we went with this sort of telephone outreach program was this has worked for us before. Right. Many of us have been involved in these sort of systematic telephone outreach programs to improve, the follow-up care for unipolar depression, for people with bipolar disorder. We've also studied that. And compared to that, this was I'll be honest, it was a pretty epic fail.
Greg likes to call this, if we want to write a paper from this, that we're going to submit it to the Journal of Instructive Failures. Yeah.
I would like to publish the Journal of Instructive Failure because it would probably be the most valuable journal ever written. So this was, I guess it was a failure. How can we make it instructive? And, to me, the challenging question is, the points of failure are many. One of it is just, for various reasons, the way we contacted people, just practically, logistically, as you mentioned, the telephone, people in this age group, that's maybe not how you communicate. There's the extra clunkiness of what the health systems restrict us from doing in terms of, you couldn't text somebody, that would be an abomination. So part of it may be that. Part of it may be, the nature of this condition, that there's something about this condition that just wouldn't work. But I'm curious about your thoughts about, or just the bad contact information. Is the bad contact information the fact that these are people who are under age 30, or that these are people whose, voicemail is full, number disconnected? So there's some challenging things about the nature of what people are experiencing that makes them difficult to contact. Tough problem. What are your thoughts?
So I guess my thoughts are that because these are low frequency, we don't have people showing up in primary care offices regularly with these diagnoses. It's hard for health systems to envision workflows that they might think about for other patient groups that are more commonly presenting in their setting. So I think the solution is probably something that where there is a suspected first episode psychosis, there needs to be some confirmation of that pretty immediately, and then there needs to be some like I said before, effort to get contact information, effort to help the patient understand that not remaining engaged in care shouldn't probably be an option for them for a while. And then we shouldn't be using phone. We should be finding other ways to do this that the patients are open to. And I think that's what we need to figure out next, is what are patients open to when they're in that early stage of development of the disorder.
So now we're ready for all of your questions.
Hi, thank you so much for all of that. The presentation was wonderful, and it's so nice to see one contiguous group of people from kind of like start to finish and actually reaching out to the patients. So I really, really appreciate that. My question actually has to do with a little bit upstream of where you're identifying the patients, of the patients are coming in and getting their first diagnosis. You kind of hinted at the major problem that for lots of mood disorders, lots of mental illnesses, especially psychosis, first of all, the mental illness literacy in the population is just so low. People don't know what to look for. Even if they have someone in their family who suffered from something, families often don't talk about it. Families often don't know very much about it or tell their children. They just hope their children won't get it, versus educating them on what are these signs, these symptoms that you should look for, and then thereby addressing the stigma against it of we have these stigmas and stereotypes about mental illness, and especially psychotic episodes, and people don't know that it's treatable and you should go in as early as possible to get treatment. And so I'm curious what any of your thoughts are about how we can address this, that issue and those issues, and how responsible are researchers and healthcare providers in addressing the literacy issues and the stigma issues. Because getting up at that upstream point might be the way we get people to engage. We get people to come in earlier before their psychosis is affecting their ability for medical professionals to reach them.
I think, as Arnie showed, we see, the data that are most readily accessible to us are the healthcare system. And of course, there's a lot of things about people's lives other than the healthcare system. I mean, if possible, we'd really want to know about people's educational trajectories. If we had all the data in the world, I'd want to know about people not showing up for school, or I'd want to know about their middle school and high school grade point average going down. Because if you follow that literature, you know that the cognitive difficulties that begin to arise may be, not only the most sort of early, but also maybe the most important in terms of people's life trajectories going off track. But we're sort of in the health system world, and I think what we see in the health system world is there's this signal, you see there, people are using more services even in the few years before, there's something going on, but the signal's not very specific. The signal may be a signal of young person not doing well. There doesn't seem to be, at least that we can detect so far, a very specific signal of not doing well because of anxiety problems, depression problems, or some more serious condition developing. Of course, that signal's important regardless. Once we detect any signal like that, what should we do? We talked, Bobby Joe talked about, using some standard instrument. What we found in these big healthcare systems is, you heard, Bobby Joe use the term workflows a few times. You can tell we come from the world of industrial healthcare. And to me, industrial healthcare is not a bad thing. If it means, standard work processes that consistently deliver quality, that's a good deal. But for us, if you say, we just need providers to be more sensitive, the question is how do you industrialize that? So what we look for is, okay, If there's a signal of some kid not doing well, how do you differentiate the different flavors of not doing well? You know, as I can't remember who mentioned, I guess it was in these, one of the provider interviews sort of said, there's not a PHQ-9 for that. And maybe the PQB or something like that is, and how would we get providers when there's a kid not doing well to, you know, to be able to detect this more specific or concerning thing?
Right, and what we hear from patients is that when they start not doing well, it's generally anxiety and depression. No one's thinking about that evolving into psychosis at that point. That's happening around age 12 or 13. And you know, the patient is hoping it's not a big deal. The parent is hoping it's something that's typical teenage behavior. The clinician, even the clinician said to us, they're hoping it's something that's typical teenage behavior or social adjustment or something, anything other than what might be emerging as a psychotic illness. And so, you know, even the PQB would be inappropriate to give most kids who are just complaining about, not complaining is maybe not the right word, but who are describing anxiety or depression, to ask them a bunch of invasive questions about psychotic symptoms they may or may not have. But then if you wait till the psychotic symptoms appear or wait for the kid to come in, you're already too late. So there's just this difficulty in detecting that early. Yeah.
Yeah, one of the ahas for me when Bobby Joe had presented the findings, the qualitative findings, was, you know, we have this big emphasis on early detection, and if we can detect early, intervene early, everything will be great. And I think the red flag here is this idea that these individuals really aren't incorporating that pretty major life change and diagnosis into their own identity. And I think it behooves us to think about, you know, how do our providers handle that kind of conversation? This might be something that unfolds over time, but, you know, getting out of the industrial sort of healthcare system to how do we put more sensitivity into recognizing that this is perhaps a bit longer process of learning to sort of understand what the ramifications of this are. And also the message, as you mentioned, that these disorders are treatable and recovery is possible. And that could be a broader message beyond our health systems, of course. We have, you know, mental health first aid and other sorts of broader types of interventions, I think, that could help us with those kinds of messages, that this isn't a life sentence for horrible outcomes.
And you know, Arnie, when you talk about that identity, I think there's a really interesting question there, because, you know, as Bobby Joe talked about, you know, this idea of at what point do you give it a label? What's the purpose of that label? To what degree is the label off-putting, stigmatizing, frightening, drive people away? To what degree is the label sort of organizing and helps people to you know, the label's got upsides and downsides. Mm-hmm. You know, when you think about lots of other sort of labels, you know, certainly, you know, I think we're at a place now where the cancer label, even though it may be frightening, is seen to have great utility. You know, it's sort of, it's a signal to, there's something here you probably shouldn't, you know, be ignoring. You know, maybe the ultimate positive one, you know, this is sort of a weird twist on it, but, you know, a positive pregnancy test is a clear label and says there's some stuff you might want to start doing and stop doing now. You know, so that's a nice example of an organizing label that's very useful. And you know, how can we make this label, you know, a better one? It is telling, I think, that the, you know, as some of you may have noticed, if you looked at both in the smaller sample, the chart review sample, and in the bigger sample we used for the mortality data, the dominant diagnosis by far was other psychotic disorder. And the people who got a diagnosis of a schizophrenia spectrum disorder at first presentation was about 15%. That's not unique to this setting. If you look at the paper Michael Schoenbaum and colleagues published, it was almost exactly the same number. They were using other large commercial insurance databases to look at first occurring diagnosis of psychotic disorder, and almost all of them are other psychotic disorder. Some of that is reality, that what is this thing as it's emerging? You know, that's sort of, you have to be as old as me to remember the Lawrence of Arabia movie, you know, but it's the, you know, as Lawrence is coming out of the desert and he turns from a mirage into a real person, how quickly can you recognize that's Lawrence? When do you start to call this thing, you know, because a lot of these, you know, coordinated specialty care programs are for people with a diagnosis of a schizophrenia spectrum disorder. What we find in our settings is if you wait for that diagnosis to be recorded, you might be waiting a long time. But on the other hand, if you too early jump and say, you know, this person has a psychotic disorder early on, are you acting too early? So there's some, to me, very interesting questions we have to consider about what labels we use, when we use them, whether those labels do good things or bad things.
I was just going to say, I think about sort of what happened with labels with the HIV population and how HIV used to be sort of thought of as a death sentence, and now they rebranded as no longer, don't think of HIV as a death sentence. This is a very treatable condition. And so I think it's almost similar to psychosis in that there's thought fear of getting that psychosis diagnosis, and in the advocacy realm, rebranding psychosis as a treatable condition, not as something that is has to be the worst thing that's ever happened to you.
Yeah. No, I think that's actually a really nice analogy. How it is that evidence for the effectiveness of treatment transforms the label to something that might actually be useful. So, I mean, we still have a ways to go in HIV in terms of people who are at high risk actually getting tested, but we're probably way ahead of where we are in terms of early treatment of psychotic disorders. From the audience.
I got a couple ideas for more papers. It'd be interesting to look at the Medicaid versus commercially insured, I think, because I don't think we've done that. So there might be, for example, well, there's a market for socioeconomic status, of course, but might be also lower functioning going forward, and differences in the mortality risks between Medicaid and commercially insured. So that'd be interesting, I think. And the other one is, I think you limited the sample to folks in integrated group practice, yeah? So that notes would be available?
These were people who were members at all, but some of the people we did not have records were people who lived in outlying areas who got most of their care in other settings.
I was going to say that if we didn't do that, then you could look at the the network folks and see whether there was a difference there.
Yeah. We did look at if you looked at incidence rate, so Medicaid, the Medicaid members of our, to be clear, because there was some, when we talked about this early on with some other people, their thought was, oh, people with psychotic disorders are on Medicaid. And we said, well, not when they first get them. Yeah. And the problem is we've developed a care system which presumes Medicaid insurance for people to get treatment for chronic mental illness. And what that means is you got to get so sick and so disabled to get on Medicaid maybe before you can get treatment, which is, to my mind, not optimal.
Yeah. But for example, like all the foster care youth would come insured with Medicaid.
Yeah, but the incidence in Medicaid insured was not much higher than the incidence in the commercially insured. Most of the people in our systems came in because they were originally covered through commercial insurance. There were some other differences, though. One thing maybe we should have put in this presentation, a paper that Karen Coleman's working on now. The pre-diagnosis utilization was quite different actually by race and ethnicity. So the likelihood that people would have received specialty mental health care prior to a first diagnosis was not surprisingly highest in non-Hispanic whites. It was about the same actually in African Americans, slightly lower in Hispanics, and markedly lower in Asians. So Asian Americans, their likelihood of receiving specialty mental health care prior to an FEP diagnosis was like less than half of the rate. So that means the identification task is going to be even more challenging there.
Thank you. I'm short, so I'm trying to turn this down. Really interesting set of presentations. I really appreciate hearing your work and the power. It's like exciting to think of what we can learn. I know there's other people with questions. I have a few, but I'm going to limit it to one. Thinking about the conversation about the predictive, how can we use this in a predictive analytic way? You're picking up a signal, right? But is there some way to sort of have it be less generalizable than youth in distress? And I wondered if there's some way, and these are probably not coded so completely in a structured or even unstructured data way, but at least as a psychiatrist, I know from my training, like often these illnesses run in families, right? And might there be some way to use the family history data that are gathered in the electronic health record to help us to try to sort through, You know, who are the individuals that maybe it's going to more likely advance to something beyond depression, anxiety, and who perhaps not. And so I don't know if you've been able to look at those data and just thinking about all the messy ways clinical care happens and information that's not captured broadly across the system. Perhaps those data are incomplete enough that it's not useful, but was just interested in your thoughts on that.
One of the things we didn't talk about here today, but we have been doing some work on text processing to say, is there any other signal that might be hidden in the notes that are written? Because as you saw, I mean, a fair number of these people have had specialty mental health contact, and then even more may have had a primary care visit where there was some mental health concern. What we've done so far is to sort of look at the obvious things. So what we did basically was we did what you would call sort of a dictionary guided text processing activity of saying, let's take the stuff from the chart reviews actually that we harvested from the chart reviews that Jen described and say, look for the terms that seem to have come up in those visits and then try to find those terms in earlier visits. You found some of them, but it wasn't that prevalent. The thing we still are working on but trying to figure out is, just turning loose some sort of pure machine learning, artificial intelligence thing on saying, is there something we never thought of that just happens to show up in these notes? Is there something that happens just about, I'm just making this up, but the primary care doctor, something just they note about the way the person looks that might somehow be a signal. You might hope for something like that. The place that, these kind of things may sound creepy to some people, but the data I would really want are from Xbox Live, because what's interesting to me is there are a lot of young people who are taking very sophisticated neuropsychological tests all the time, every day. They're called video games, but wouldn't it be interesting to look at someone's trajectory in their video game performance and see what that looks like? Which, the other thing would be their trajectory in terms of their school performance or something like that. My guess is the signal might lie more there.
Mm-hmm. Thank you.
I would also say that we've thought a lot about these things and are doing various work in machine learning and predictive models and all, and they don't always, give us everything we want at that point. And I think the way I've started to think about it is in a more longitudinal way, where if there's a risk signal, that individual gets into a sort of a higher level watch list over time with more consistent follow-up, because some of these things may not be determinable at the initial sort of risk period or the things that, at the first presentation where various things come up. And it's usually something over time, I think, that can happen. And if so part of that is just sort of engagement in a sort of a higher risk group where there's follow-up. And part of what we struggle with all the time is these individuals sort of falling through the cracks, lost to follow-up, difficulties engaging. So I see it as a sort of a longer period. And we have great systems now for that process in our electronic medical records for identifying and tracking people who have various encounters, or if they don't have encounters, needing to reach out to them.
One of the things I was going to say about the follow-up, one of the things we observed, that in what Bobby Joe showed about the utilization after diagnosis, the likelihood of some, follow-up outpatient contact early on was actually really encouragingly high. And then we realized, there's a HEDIS measure for that. That a lot of these initial contacts happen in an inpatient setting, and 7-day follow-up after an inpatient mental health stay is a HEDIS measure. And all of the health systems that are involved in this are all over that HEDIS measure. I know in the health system where I work, every day in the daily huddle in the mental health clinic, you say who's due for what the jargon term is 7-day post. Who's due for a 7-day post, and did they come in or not? And I think that sort of, that focus on that. But what we talked about is, what about the 6-month post? Do we need a HEDIS measure? Because if you see these really high rates of early engagement, but then really high rates of disengagement from care, do we need to have a, what's your documentation 6 months after such a diagnosis that you even know what happened to people? And maybe we need a HEDIS measure for that.
Hi. So my question was also to do with the idea of working with patients who have health coverage from different payer sources, public and private. So thinking about following patients from the whole spectrum of, pre-diagnosis all the way through post-diagnosis follow-up, have you looked at the idea of using different incentives that are built into different payer models in order to kind of improve these different systems? For example, in private payers or with accountable care, you have, the HEDIS measures or, different preventive care metrics that systems are already held to such high standards of kind of, follow-up and getting people in, thinking in the Medicare population, for their annual wellness visit. There are financial incentives tied into that. And I know that with Medicaid managed care, there's already a lot of telephonic outreach to make sure that people come in for their diabetes A1C testing and things like that. Is it possible to kind of map those already fairly common techniques, especially in integrated health systems like Kaiser Permanente, to efforts like this? Or because first episode psychosis is such a low incidence condition, is it considered a little bit more difficult to kind of generalize those techniques?
I think you're along the right line. I mean, in some ways you say, can you identify some point of leverage, something where you could say, can we shine a light right there? And would shining a light in that place motivate, behavior that would have broader positive? And, the existing HEDIS measure about follow-up after psychiatric hospitalization, I think, is a great thing. I mean, I think it really gets health systems to focus on something that is important. I think people are on board with that. Everybody agrees. And the question is if you had one more measure, if you had one other thing where you were trying to say something about the ongoing follow-up, what would you measure? And would you measure something, now that, as many of you know, HEDIS is moving beyond just measures that are based on claims, but what they call, I don't know why they adopted the term ECDS, or Electronic Clinical Data Systems measures, which most of us would just say means EHR. What it really means is measures that come from a health record, not just from an insurance claim. They're putting out ECDS measures that are based on outcomes of depression care. Did your PHQ-9 score get better, basically? But the question would be, for more severe conditions, what would be some good measure that would somehow, the challenge is, some of you may have heard Jürgen Unitzer talking this morning about, what I would call sort of a combo measure, when they were talking about collaborative care, because the measure wouldn't be everybody has to have a good outcome, but you either need to know people had a good outcome or that you tried to do something about it. So the kind of measure you might want to see for this, I'm just making this up, but you might say, okay, people who've had, it doesn't just have to be a first episode psychosis diagnosis, but someone who's had some acute care mental health, seriously concerning episode, whether it's a first episode psychosis diagnosis, a psychiatric hospitalization, an emergency department visit for a self-harm episode, you actually could put a lot of things into there. You could say, pick your time period, whether it's 3 months or 6 months later. What you need to have is you need to show either that the person got better, that they're really engaged in appropriate care, or that you've made, a pretty vigorous effort to reach them and they didn't respond. I mean, we don't want to hold the health system accountable for behaviors the health system can't control, but we do want to hold the health system accountable for the actions that it should be held accountable for. This is, I think this is where we need to go for things like this. Coming up with those kind of measures is complicated. It's funny, a lot of us are also involved in a project focused on this related to suicide prevention. And there is as you may know, there's an upcoming, I don't know if it's officially released yet, but there's going to be a HEDIS measure for follow-up after emergency department visit for self-harm. But it's an interesting question about what's follow-up, because follow-up, the obvious follow-up is somebody made a visit. But what we'd like to document is, did people do enough outreach for people who didn't make a visit? How do you measure that? And how do you measure it in a way that's not, I don't know how to say it, this sounds bad. How do you measure it in a way that's not gameable? Because in some of our health systems, when we've tried to develop internal measures related to, you need to have at least called the person 3 times to show that you did the right thing. I think we could all imagine how you could call somebody 3 times and with minimal effort and have very low likelihood of reaching them versus calling them 3 times and actually reaching them. It depends on when you call, you know. If I call somebody and they don't answer and I call them 2 more times, right now they're not going to answer 3 calls, I'm done. You know, that's not a very good quality measure or quality metric. So I think you're asking exactly the right question, but there's some interesting complexities about how we identify the really specific actions we want to make sure people do, and it's a bit complicated because you're going to need sort of combo quality measures. You know, either this happened, or neither of those things happened, but you did your best to make it happen, and how you measure all those things. I'm not meaning to say we shouldn't do that. I think this is exactly where we need to go, but we just need to be really careful about how we define those things, I think.
And I'd add to that, the last part of your question was, is this such a small frequency that it's a problem for health systems? And the answer is, I think, yes. And one of the things is our systems aren't necessarily structured to provide the full range of services that some of these individuals might need. And so part of the equation here, I think, is do we have good enough referral and feedback loops to other types of services, like in community mental health centers, that might provide sort of a better wraparound set of services for some of these patients. So I think it's important to acknowledge that we aren't necessarily well set up to provide all the kinds of services that some of these individuals would need, and we need to do a good job of partnering with community agencies that do that as part of their business and are held accountable through various quality indicators, like Medicaid.
Yeah. But I think the incidence of severe mental illness in younger people is on the order of the incidence of type 1 diabetes. And we probably would say if some 12-year-old was diagnosed with type 1 diabetes and 3 months later we didn't know what happened to him,
Yeah.
we'd probably that's not good.
Yeah.
I'm interested in the panel's thoughts on where first episode psychosis research is going, how we're going to make breakthroughs. So we've, a bunch of studies now among people with a first episode psychosis look back and see what kind of signal there is in the record. And, I think if I had my way, there'd be a $50 million study where we enroll pregnant women and follow 30,000 kids forward in time until they're 30 years old and see what happens to them, right? So maybe that's a multi-institute thing, and we can all look at different things in this big cohort of folks, and I can think of some people who might want to lead that. So anyway, how are we going to break through in some of this stuff, do you think?
Well, NIH does have some significant, ABCD study, NIH has some significant investments in this area that are attempting to do that. I think to me the big challenge is that how do we, given that the way that young people interact with the world, and especially interact with various technologies to interact with the world, is changing so rapidly that a longitudinal study that's using, the way things work today, by the time that study is very, that's to me that's a really interesting challenge. You say, I don't know, it would have been not that many, years ago when we would have said, how are people interacting on MySpace, Now, Facebook, has replaced MySpace, although I don't think that kids don't use Facebook, So, then you get to, and this stuff is possible if you said, okay, if kids are all on, I don't know, I'm old, so they probably aren't even on Instagram anymore. But
Fortnite.
Yeah, what's that? Yeah, but what it means is, if we've somehow, if somehow we're saying we're going to look at the text strings that people create and search that to try to understand how their brains are working, then we say, wait a minute, people don't make text anymore; they make images. How do we look then at the images that people create? How would you look at the pictures that they choose of other things, and the images they create of their own face that would tell you something about how their brains are working? But then, I would be loath to predict 5 years from now.
And if they're isolating and withdrawing, then they may be isolating and withdrawing even from those technologies that you might be looking for some.
Although that would be really interesting to know. I mean, we don't even know that, of course. But so I think you're asking exactly the right question about where in the world is the data signal that would tell us, who's doing poorly. But the nature of the data signals we need to interpret changes so fast. What would you need to know about people's, people's media consumption habits? What would what they watched on YouTube? Those kinds of things. There has to be. I'm sure there's something there. If we only, could find it and then find it in a way that, the human brain is not evolving every 5 years. I mean, because what we're really trying to measure is what's happening in people's brains and minds. And, what we're looking for is some signal that's out there in the rapidly changing technology world that tells us about that. So how is it we can come up with some enduring idea of the thing we're looking for while the thing we're using to measure it is like completely turning over every 5 years? Once again, I'm not trying to be pessimistic about the question. I think that is the question. But it's a really interesting and challenging one, I think.
So I was wondering how you guys were thinking about, or if you were thinking about leveraging the algorithms that you've already developed to kind of elevate what you're finding to a population mental health level. So either aggregating information on a county level and linking with county level social determinants information, either in BRFIS or other locally available data sources to kind of understand how those might be affecting the early diagnosis.
That's actually when you think about that, it suggests a really interesting idea that somebody, maybe you, should do. So because we're using data elements that are pretty common, readily available. I mean, these are just diagnoses and procedure codes and things like that. There's nothing very fancy about that. All the code is on GitHub. You could go find all the code we've used there. But now that, for instance, a lot of states, the thing that we've been able to do, which is to bring together a lot of data sources and have a comprehensive view of healthcare use by any individual, a lot of states have all-payer claims databases now. So it would not be that difficult to take some of this same stuff and take a whole state and use the all-payer claims database to say, what does it look like the incidence rate is in our state and where is it? I think you probably could, at least get some geographic information from all payer claims databases. You'd have to negotiate about that, I don't know, how many digits of zip code would they give you, Could you get 5? You probably couldn't get 9, maybe you could get 5. But that might be good enough. So some of that, being able to take this up to a state level, is certainly possible to do, I think. I mean, we could do that because we have that information, but now that they're all payer claims databases, somebody else could do it just as well or better.
Yeah, interesting question, and the technology is there to do this. I've done some work in that area with the depression, actually linking individual encounter data with American Community Survey data at the census tract level, so that you can pull in not only sort of individual level factors that might confer risk, but also community level factors, and that can be a whole host of things you're probably familiar with. So it's actually doable, and it could probably be doable with the all-payer claims database as well. So there's some interesting opportunities to do more with that kind of technology now with linkage and to look at the influence of place and social determinants.
So I think we're about at our time. Want to thank you all for coming, contributing to the discussion. We should have put our email addresses up there, but if you can't find them, you can come get it from us. If any of you are interested, as I say, a lot of the tools we use, the code, the chart review things, if anybody wants that, we love to give our stuff away, so just ask us. Thanks.